Hi, my name is Sarah Griffin. I'm the owner and founder of Edge Clinical Nutrition. I'm an experienced college nutrition instructor. I'm also a currently practicing ICU dietitian with almost a decade of clinical experience. And I make two products currently. I sell a nutrition support skills course and a CNSC exam study guide that were recently nominated by the Dietitians in Nutrition Support DPG for an Excellence in Practice Award from the Academy of Nutrition Dietetics. So all that to say, I function to teach students the ins and outs of nutrition support. I live and breathe teaching nutrition support. This is my bread and butter. It's what I wake up thinking about. My students have told me I have the unique ability to translate really complicated topics into things that make sense. And I will say, I have been frustrated over the years by finding guidelines and resources that just like throw guidelines at you and present guidelines. And I think acid-based balance is no different. I Googled prior to this lecture acid-based balance quick cheat sheet or video lecture for dietitians. And there are some one-page PDFs that you can download for free on the internet. But here's the thing. Free resources usually aren't very helpful for teaching. They can present guidelines. They're great at presenting guidelines. If they just give you a one-pager that says like, here's basics on acid-base disorder, that's great. But they don't actually teach you anything. They assume that you know the background and the all of the biochemistry and physiology and chemistry that goes into this. And a lot of dietitians don't because we weren't taught this in school. This is one of those areas where like medical, pharmacy, biology, chemistry kind of rubs up against dietetics. And lots of us were never taught this in school. I was never taught this in school. I've always had a hard time in rounds feeling like there's conversations that are going on around me and I can't participate in them because I don't understand what's going on. So if you feel the same, if you feel like when doctors and respiratory therapists start talking about acid-base balance, your brain just goes blank and you tune out, this lecture is going to be really important for you because it's going to help you actually integrate with the nutrition support team and with the interdisciplinary team. And you can actually be a really important component of that team recommending, hey, maybe I can increase acetate in the parenteral nutrition order, or maybe I can increase chloride in the parenteral nutrition order. Let's see if that helps. You can actually provide some of those recommendations, which is a really cool way to practice at top of scope, which is another thing that I'm very passionate about. So I'm going to give you a preview here and explain some of my big picture concepts about acid-base balance, but be aware that this is a full lecture inside my nutrition support skills course and my CNSC exam study guide. You can get the full lecture. You also will get these beautiful acid-base balance cards that really are an awesome visual teaching tool. One side is alkalosis and one side is acidosis. These are intentionally designed very thoughtfully by me as a visual learner because the color coding really matters. And at a glance, even in ICU rounds, these are small enough and covert enough that you can just take a peek at them in rounds so that you can actually remember oh yeah, that's what they're talking about. That's what that means. And you can participate in the conversation. And then the other card is just kind of quick overview about acid-base balance in general. So these are super duper handy for anybody who's practicing in clinical nutrition and wants to practice at top of scope. If you're studying for the CNSC exam, you need these because they will ask you lots of questions about acid-base balance. And this is one of the number one issues and reasons why people don't pass the CNSC exam is because they don't understand acid-base balance. Now, the CNSC exam used to be separate exams for dietitians, pharmacists, nurses, and dietitians, pharmacists, and nurses, and now it's all one exam. And so you're getting nursing level questions, you're getting physician level questions. And so that's why this exam is so hard. Okay, so let's go over a few basics. First of all, on the screen, I provided reference ranges for our typical acid-base balance labs. Now, it's really important to commit these to memory. Inside the CNSC exam study guide bundle, you get access to flashcards. There's 112 flashcards alone on numbers that will really help you commit all of these pesky numbers to memory. So reference ranges for common labs, reference ranges for electrolytes, how much to dose in your parenteral nutrition order, RDAs for certain vitamins, all of those are in the flashcards. It's going to be very difficult to pass the exam without memorizing these. So these are really, really key. In clinical practice, if you're not taking the CNSC, you probably don't need to memorize them because more than likely your EMR will show you if a lab is high or low. It'll our EMR, for example, turns green when it's normal, red when it's out of range. So typically your electronic medical record system or your charting system like Epic or whatever you have will kind of cue you into that. So if you're not planning to sit for the CNSC, you just want to become a better clinician and practice at top of scope and be more savvy with this kind of stuff, you probably don't need to worry about memorizing these. But these are really important for CNSC candidates. Now, our normal PCO2 from an ABG, an arterial blood gas, now that's from an ART line, an arterial line, so it's freshly oxygenated blood coming from an arterial line. We typically have these in ICU patients. Patients on the floor typically won't have an ART line. That's between 35 and 45 we like to see. A normal PO2 is typically between 80 and 100. A normal bicarb is usually 22 to 26, and bicarb is HCO3, and a normal pH is 7.35 to 7.45. Now, if you remember from school, maybe from like basic chemistry or organic chemistry or biochemistry, which was always one of my hardest classes, our body has a very thin range of pH. It likes to keep the pH kind of in this baby bear range between 7.35 and 7.45. And if it gets out of whack, if it gets out of those ranges, the body will work really hard to compensate. So for example, if the blood gets too acidic, now acidosis is going to be acidic, lower on the pH scale, so below 7.35. The color coordinated scale in the middle, it's towards the top, getting more acidic. Sometimes pH scales are sort of horizontal as well. This one just fit on my screen better. So the pH is going up or to the left. It's getting lower, more acidic. Let's pretend your patient has diabetic ketoacidosis, which happens a lot. They forgot to take their insulin because they were sick, and their body just has a ton of blood glucose in the blood, but because insulin is the key to unlock the cell so that blood glucose can come in and be metabolized, and there is no key, there is no insulin to unlock the cell, glucose is just floating in the blood and building up and building up and building up, right? So diabetic ketoacidosis, let's pretend that that's what's going on with our patient. Now, I mentioned there's compensatory mechanisms, and when you read literature about acid-base balance, there's some really great articles that I referenced in the last part of this lecture that I recommend you read. You can also read the Aspen Core, but again, sometimes these are really, really complicated, and if you don't understand the background or have somebody physically teaching you, it's really hard to understand. You'll see this word compensatory mechanism, and you'll probably wonder what that means. So our body, when the pH gets out of whack, the body works really hard with two primary mechanisms, the lungs and the renal system, so the lungs and the kidneys, to readjust acid-base balance, or readjust pH particularly, so the blood pH goes back to homeostasis, to that normal like 7.35 to 7.45. So let's put a pin in that, because I'm going to explain like sort of a case study of that in a minute. But I want to go through a couple of other important things before we talk about that. But just know that the body has two primary compensatory mechanisms, the lungs and the kidneys, which work very hard to adjust and keep the body's blood pH into a certain range. And the lungs work very quickly. So they compensate within minutes because the lungs are constantly breathing, constantly doing their thing. They can affect the blood acid base balance very quickly. The kidneys take much longer, 2 to 3 days, for renal compensation to occur. So let's put a pin in that, and we'll talk about that more in a second. Now, hydrogen ions, H+ ions, are acidic. PCO2 is also acidic. So if you have a PCO2 from an ART line, an arterial blood gas, PCO2, which is not the same as CO2, but PCO2 and H+ ions, those are both acidic. Carbon dioxide is a waste product of cellular metabolism. When carbon dioxide combines with water, the reaction forms carbonic acid, and carbonic acid dissociates to hydrogen, acidic hydrogen, and basic HCO3 or bicarb. HCO3 is that basic component, the bicarb component. Acetate and parenteral nutrition, which is included in our amino acids, is metabolized into bicarbonate. So that's really important, because in the full lecture, I'll teach you how to adjust for acid-base balance in parenteral nutrition. It's not just balancing it 1-to-1. We actually have a lot that we can do to affect a metabolic acid-base disorder in your parenteral nutrition order. Now, proteins, of course, serve as buffers. We know this. Proteins can serve as buffers in the blood. And then two other really important things to keep in mind. Metabolic acid-base disorders are a primary disturbance in bicarbonate, and respiratory acid-base disorders involve a primary disturbance in CO2. Now, this is really important and very nuanced and complicated, but because there is compensation, you will start to see the labs skew towards normal or skew to the other side. Meaning, if your patient has an acidosis and there's respiratory compensation and renal compensation, the labs will start to skew towards normal. So if you check labs, you check your acid-base labs on day 2, for example, of an acid-base disorder, you might see the labs starting to skew towards normal. And that's why it can be hard to determine what the primary issue is. So typically, intensivists, ICU doctors will try to diagnose acid-base disorders like right when they happen, pull an ABG, the The respiratory therapist will pull those little tickets from the machine to get the lab values and look at those to determine what's going on and decide what's the primary acid-base disorder. There is compensation, which is good, right? We want things to start skewing towards normal. But if you kind of catch the labs after compensation has started, it can be difficult to determine what is the primary acid-base disorder and what's the compensation. So maybe it's acidosis, that's what's happening because your patient has diabetic ketoacidosis, but the blood's starting to get more alkaline because it's trying to compensate and get rid of the acid. So that's why this whole discussion can be kind of tricky. One other point I want to make, it is not within a dietitian's scope to diagnose or treat metabolic acid-base disorders. This is very important. So we would never diagnose this. We would never be like, oh, I know this. I see the labs and I know what's going on. And I'm going to chart that they have metabolic acidosis. Do not do that. That is not within your scope. The doctor needs to diagnose that. Once they've diagnosed it and charted it in the permanent medical record, we can copy behind and say the patient has metabolic acidosis. This is what I'm doing in the parenteral nutrition order to compensate for it. Another super important point, and don't click away because this is actually like one of the most misunderstood things in acid-base adjusting in parenteral nutrition orders. You should not adjust a parenteral nutrition order. Do not adjust the acetate or the chloride ratio for a respiratory primary disorder. Let me say that again. If your patient has a respiratory acidosis or a respiratory alkalosis, do not adjust for it in the parenteral nutrition order. I have seen so many resources on acid-base balance for dietitians, and very disappointing to me, very few of them will say this. This is one of the most important things that you have to keep in mind. And why is this important? Think about it. If your patient is overbreathing the vent, or if they're hyperventilating, or if they're having some respiratory issue, you can put as much chloride or acetate in that parenteral nutrition order as you want. It is not going to fix the issue if the issue is primary respiratory. So that's a respiratory therapist, probably in collaboration with the doctor. They need to collaborate and kind of suss that out. If your patient has a metabolic acid-base disorder, we can adjust the parenteral nutrition order. So balancing chloride to acetate 1-to-1 is something that we can do. In fact, what we do for most patients, but for some patients, they really need more chloride or more acetate. And so it is important to be able to understand when and where and why we would add more chloride to acetate to the parenteral nutrition order. And I explain all of that in the lecture. Okay, so in the Nutrition Support Skills course and the CNSC exam study guide, I have these great acid-base balance cards. There's one on acidosis and one on alkalosis. I'm a teacher and I'm a very visual learner, and so I've designed these specifically to be a really great learning tool because they're all color-coded. They tell you exactly what's going on with respiratory and metabolic acidosis and alkalosis, and then there's a second card that just talks about all the basics. These are fantastic because they're not just guidelines thrown at you, but they're actual like teaching tools that will help you to remember this content for ICU rounds when it comes up, when you're texting with a doctor or talking to them in person and your brain just freezes and you don't know what's going on. You can pull these out and look at them really quickly. So I can't tell you how many times in rounds they've said something or they're talking about something, and I just like kind of covertly pull this out of my binder and take a peek at it to try to remember and jog my memory and be like, oh, that's what's going on, and that's what I need to do with the PN. And then I can speak up and be like, oh, I think we should increase the chloride in the PN. I think that would really help. And everybody's like, oh my gosh, great idea. And I'm like, yes, thank you. Pat on the back. That was awesome. I think it's so important to have these teaching tools with us because you can carry these with you to rounds. There is no shame in like looking something up. I think it is much worse to make a decision, especially in terms of patient care, to make a decision based on something you think is right, but you're not 100% sure. You need to check, you need to verify. So these will help you so much in rounds, and you can access these inside my course or my study guide. So to access the full lecture, which is almost an hour long, purchase the Nutrition Support Skills course or the CNSC exam study guide, and you can find details in the comments.